Hello, this is Oleg Borisenko and Market Access Insider channel. In our programs, we discuss organization and financing for healthcare services and medical technologies in European countries. Today, we're in Paris, France, and we're going to talk to Michel Verhasselt, the founder and CEO of Meditech Access France, one of the best reimbursement consultancies in France. So we're going to cover a broad range of topics, including organization and financing of healthcare services, including DRG and add-on reimbursement, as well as innovation funding schemes. Hope you will enjoy the program. Can we switch to the innovation funding topic? So France is well known for its number of innovation funding programs. Could you outline the possibilities for medical technologies?
Yeah, so there are basically, I would say, three possibilities. One, let's talk about the national funding. There are some regional funding that, or even local funding that you can consider. But regarding the national, there are two blocks. One block are the national clinical programs. Mm-hmm. The other one is the innovation package. Mm-hmm. So regarding the hospital clinical programs, they are initiated by either medical team mm-hmm. or hospitals. Mm-hmm. So the industry don't have control on the direct control on the process, and officially the submission is executed by hospitals and medical groups. So these are the pure clinical programs called PHRC mm-hmm. or the health economical programs called PRME. Mm-hmm. There is a selection process. And this funding will pay for the clinical study, but only a part of the cost of the device, a small part. So that's, and if you want to go through this pathway, it's because, for example, this is in your interest to have this clinical study funded, mm-hmm. and maybe a smaller interest to get your device paid. And also you are 100% sure that your relationship with the clinical team of the hospital is strong enough mm-hmm. so that, or you are confident enough because you don't have a direct control on the protocol mm-hmm. and the clinical execution. So you're confident enough so that this program is aligned with the strategy. The other possibility is the innovation package, mm-hmm. and the process is 100% not 100%, but officially the submission process is the same as the LPP, is on the control of the company. Mm-hmm. The submission is done by the company. Mm-hmm. So this is an official process which is normally 120 days, about I would say 75 days, I guess, between the day of the submission and the HAS decision. Mm-hmm. And then the second part is the Ministry of Health mm-hmm. Decision on the DRG value, because the innovation package is a kind of DRG. Mm-hmm. Not for all French hospitals, but for the hospitals which, because again, so the innovation package is a funding of the medical device, mm-hmm. and in this particular case, the company has to pay for the clinical study, mm-hmm. but the device is paid and reimbursed, mm-hmm. but only in the centers which are part of the protocol.
All right.
So actually, a forfait innovation package is a protocol plus a kind of LPPR dossier mm-hmm. and a budget, mm-hmm. because the company has also to submit a budget to the Ministry of Health, a budget for the clinical study, a budget for what will be the new innovation package, which will be a DRG-like mm-hmm. Funding. And the third will be the cost of the, because usually this is a comparative study, so there's a experimental and control arm, you have to evaluate the cost on the control arm as well, which will be paid by the social security as a common reimbursement, existing reimbursement condition. So the innovation package is between submission and the decision is normally 120 days, but again, there can be clock stops, so it can be a little bit more. And then, so that can be a very interesting and promising pathway, although the first dossier has been very not so. So there has been a very strong enthusiasm when the Forfait Innovation has been created, but the implementation has been a lot slower than expected.
And what's the current status of the program, for example? Like what did they recently award?
There's a recent increase. So still it's difficult, but for example, there have been 2 sets of, and probably there will be a new versions coming in the next months, but there has been 2 versions. The very first version was really, really difficult to implement, and there has been only 2 devices which has been reimbursed with this process. Then there's been a new version in 2015, and today there has been, I think, 3 or 4 devices which has been reimbursed. But there's an increase of positive advices coming from HAS. So it's been very slow in the beginning, but now we can feel that there's an increase.
And so what's the overall objective of innovation package versus the normal reimbursement versus PHRC, PRME?
Okay, so this is a coverage with evidence development mechanism. So it means that, of course, the idea of the beginning is, so we have a promising or innovating device, and we don't have the adequate clinical evidence. So it's possible to implement the required clinical study that the LPPR will look, and between the day of implementation of the clinical study and the final reimbursement, you can benefit from this conditional reimbursement. So, and there will be a first part which will be the clinical study itself, and as I said, company will pay for the clinical study, but the device will be reimbursed in the selected centers. There will be a second part which will be between the end of the clinical study and the final evaluation from HAS. Again, in those 10 centers, even if the clinical study is finished, they will still be reimbursed. In a limited budget, but still they will still be reimbursed, which means that once you have the positive evaluation and acceptance of these innovation DRG, you know that basically, except if the clinical results are negative, which hopefully will not happen, but you're on a very clear pathway, which normally will end up to LPPR decision.
And the difference with PHRC, PRME is that those programs are more like study related, right? And then it's limited coverage for the technology, right? Exactly. Versus with innovation package, it's more like complete.
Normally, yeah, I would not say it's 100% because there still be a negotiation for the price. And so the idea of these authority would say, okay, so this is, for example, because we had some discussion with the health authority, and they say, okay, so we will pay for the device, but we don't want to include marketing and commercial costs. So basically, yeah, there's a little, but still, so this is basically the total cost of the device, which are taken into account in this, and also, and also because it's a DRG, there's still room for negotiation with the hospital, even if the DRG, the package is calculated by the Ministry of Health. Then on the field, you can apply your tariff.
All right. So France also has a very unique national pilot in telemedicine, ETAPES program.
Yeah.
So could you elaborate on this program?
Right. Yes. So this has been very so. Although it's not optimal, but I think it is quite unique. So it started in 2010 with a decree on telemedicine, which will include the 5 pillars of telemedicine, which is teleassistance, tele expertise, consultation, etc. So there were 5 different pillars. Then there was a second, after 2014, they were starting some experimentation, but the French authority decided to first implement this experimentation in 9 regions only, and for a limited period of 2 years, and only for teleconsultation, tele-expertise, and certain therapeutic areas. Then these first experimentations were finished. For example, tele-expertise and teleconsultation is now finished, and now this has become a new reimbursement. So it has been an experimentation between 2013 and 2018, and now it's reimbursed. But then they evolved and say for chronic disease and remote control, they will implement a new experimentation first 1 year, now it's 4 years, starting in 2018 until 2022, for heart failure, renal failure, diabetes, and COPD. So for those 4, they created a kind of scope, which all the details on indication and patient's population, etc. And it also, there were some discussions on who was going to pilot those experimentation. At the end, the final decision was interesting because there was some hesitation between choosing the regional healthcare agency or the healthcare professional, hospitals, and the final decision was that the experimentation will be implemented in 3 blocks. First, a technical solution, which can be conducted by healthcare providers and companies. Second was the healthcare professionals, and the third were the physicians. And everyone has been assigned a specific tariff, 110 euros per 6 months for the doctors, 60 euros per 6 months for the HCP, and 600 euros. 300 euros, between 300 euros and 375 euros for the technical solutions every 6 months, with the possibility for the technical solutions to get directly paid by the Social Security. So that will be this is working today. So the only thing that the companies has to do, if they have developed the technical solution, is to declare their solutions on the website, at the Ministry of Health.
But is it still an experiment, or is it?
Yes, this is an experimentation, and then during these 4 years, 2 recommendations or 2 objectives. One is a global objectives, because these 4 years experimentations will be globally evaluated by the evaluation agencies, which will make a report proving that this is interesting or not interesting, or if there's room for improvement, or if they want to keep it the way it is today. So there will be a global evaluation. And for the companies which have their own solutions, they also are responsible to develop in parallel their own clinical evidence for their own solution, because we know how the French system works, how, whatever the solution, the final solution will be, we know for sure that there will be some clinical evaluation at the end. So you can be prepared. And just for your information, there were two solutions that already developed clinical evidence. One was for diabetes. It was called the Diabeo. The other one was for heart failure. It was called Cordiva. And they both submitted a dossier to the HAS, but this was before the beginning of this experimentation. So they decided not to move forward because of this experimentation. But of course, for example, if we consider these two solutions, so they are prepared to get into the new system which will be agreed or implemented after this experimentation process.
All right. Yeah, that's very interesting. So another innovative approach is Article 51, right? Approach.
Yeah.
Could you elaborate on that concept?
Okay, so I mean, Article 51 is, there are two objectives. One is what I already mentioned a little bit earlier, is probably to move from the pure act system, which is a real concern in the French system. So I told you about these 6 years, but okay, so this is one problem. The other one is that, and also it's related to the act, it's because this system focuses on the therapeutic event without taking into consideration prevention or follow-up. So that's, and also there are many cases in the system which are not optimal in terms of, clinical follow-up of the patient, because again, so for example, the patient can be treated at home and then in the city, and then it gets to hospital with a completely different system. So they want to open up the system and create some bundling mechanism in order. So this is the philosophy of the system. So I would say, again, just to summarize two things: get out of the 100% act system, and second, create some bundling mechanism in order to integrate for certain patients prevention and follow-up, and not focus on the therapeutic event. Something which is also very important in Article 51 is to also evaluate the possibility to reimburse new technologies which are not today eligible to either DRG or LPP, like connected health, artificial intelligence, softwares. So, and we know today that there are some application and softwares, algorithms that will either benefit the patients the same way as medical devices, or improve impacts on current impact on the patient. So dramatically improve them, or improve the effect of a drug, or improve the effect of an existing medical device. So basically, this was really difficult in the ACT system or current reimbursement system to evaluate these new devices, actually systems or softwares. So this is also, and of course, there's a conjunction because between making it possible to reimburse and also open up the existing system. And again, there will be some experimentation because they don't want to reimburse any new application or software. So they, and exactly as I explained you with the ETAPE and telemedicine process, this Article 51 will also finish certainly with the same philosophy as the one that we have today, with some clinical evaluation before and then reimbursement. And also, there is today a connection between the telemedicine and ETAPE and Article 51, because for companies, except, the ETAPES program is eligible today for chronic disease, the 4 chronic diseases which I mentioned. But if you have a new e-health program today, it will not go into ETAPES because ETAPES is closed. Then it has to go to Article 51 today.
Right.
It will be also part, e-health will also be part of this new experimentation program.
But is Article 51 regulation is like strictly local? For example, it's just one experiment, I don't know, few hospitals, something like that, or could it be
both?
It could be at broader scale as well?
Both. You have 2 different pathways. So, for example, imagine that your company, you have a program that, imagine it's based on the softwares, but instead of being executed in the hospital, you can do it on the PET scan in the city, and it will avoid some hospitalization potentially. So you think, oh, this is not reimbursed, but this is probably an Article 51. So either you go through regional agency and you want to focus on the region, that's one pathway, or you think, no, it will probably have a broader impact, so I want to go national. So then there's a technical office at national level, and you can organize a meeting with this office and talk with them. And then, of course, you have to make a letter of intent, and there's a selection process. But a company cannot be alone. I believe that if you present a consortium with a group of doctors, a group of hospitals, a group of maybe also represented by a patient association, and the solution, you have much better chances to achieve it, to get a success, rather than just being alone.
All right. So very interesting, both local and national.
Yes, local and national.
Possible. Okay.
Yes, and if, for example, you can go to the regional agencies' websites and tap Article 51 and find all the documentation needed to submit. Or you can do the same on the French National Ministry of Health website and get the same documentation.
Excellent. So I just want to briefly talk about another innovative finding program in France dedicated to in vitro diagnostic tests, RIHN nomenclature. So could you elaborate on the meaning of that?
Right, so this is a little bit a parallel of forfait innovation, but for diagnostics. So this is exactly, the health authorities which have elaborated the forfait innovation are the same ones that have elaborated these RIHN diagnostic program. Same philosophy. It means that, so I don't want to go into details, but it's been set up in 2015. Normally, there's a first set of 3 years funding mechanism for the diagnostics. So this is again a clinical study in parallel with a funding. And if the results are positive, then it can get to the classification, which is NABM for the diagnostics. And if it's not, then they can also enlarge the evaluation by 2 other years. And normally there's a yearly evaluation process. So every year they look at the devices, the diagnostic devices which are on this process, and so there's a selection process going on, and the others which has to be put out. But this is new actually. Today there's only be, I think, 1 device which has been which has benefit from this process and has been eventually passed to an ABM.
Yeah. But also, right now it's like about 400 tests on this list, and it's rather stable, right? So it probably will take some time to fully implement that. Can we just discuss the general trends in financing or again reimbursement for medical technologies in France? What to expect in the coming years?
Well, the big challenge is Article 51, because I think basically my feeling is that the ACT system is a real concern. because it's not very efficient. So that's one aspect in terms of a company, because of these very long and uncertain process. So this is something which makes it difficult to get innovative. But not only. So the base of that is the Act makes it very difficult for the payer to control the relationship between the patient and the doctors. And this is because of that problem, because they are completely independent. So there's some cut between this relationship and the control from the payer. So the payer wants to get more control on this relationship, and replace these Act mechanisms by something different. But also the result of that, and we can understand the payer and their reluctance to create new acts, and also to want them to be strongly evaluated, because the more they will accept, then the more money they will have to spend, on which they will have no control, or almost no control. So I think this is really not working well, and there are many stakeholders which would like to replace it. So, and again, I think that what we can see with this Article 51, and this is really what even the Ministry of Health kept repeating it, so they want eventually to at least partially replace it. So that's one trend. Regarding, there's also big questions around DRG, but my opinion is that, okay, so if the DRG mechanisms is not perfect, we can see the global trend that almost all countries are moving toward DRG mechanisms. And I think this is probably not perfect, but this is the last, maybe a good compromise between other, global budget or other mechanisms. And I don't believe that we have identified new hospital fundings which are better than DRGs.
Yeah, outcome-based, but they're very complex, right? And couldn't be really implemented at broad scale.
And other countries, we can talk about the recent trends on Belgium, for example. Belgium has been very long to get to DRG, but they are starting today to get into DRG. So, so DRG will probably be kept. Normally, the LPPR mechanism in France is interesting because, so it is a huge challenge, but once you get it, it's very, very interesting. It's interesting for the company, but it's interesting for the system because they have this possibility to make sure that we will accept a reimbursement just at the condition the drug or the device has proven its efficacy, its efficiency, health efficacy, etc. So I think the system is good, but it should be a little bit more equal, fair. Rules should not change because this is also a big concern regarding the French system, is that a rule which is true 10 years ago is no more true today. So, but the time to set up a clinical study is long and expensive, and this is not a good sign to show to sometimes global headquarters that it's very important to set up this kind of clinical study in order to get into the French market and get changed 5 years later.
Yeah.
So stability on the rules should be kept. So at least, even if there are small adjustments, but just to keep the same types of clinical requirements.
Michel, and probably the final question on France. So what are the most typical mistakes done by the medical device companies when they enter the market from the reimbursement perspective?
The biggest mistake is to believe, for example, that they should make some compromise on the clinical evidence. One big mistake is to think that, okay, so we have a very strong clinical trial in the US, and we will do a small registry with French centers because we need French data. This is a strong mistake because this registry, even if it costs a little bit of money, of course, but this methodology is so poor so that the French authority will even not consider it. It's not a lot. I mean, the French authority actually, it's a nice to have to get French data, but it's not an obligation. It's a lot better to put the money into a stronger clinical study, even if it's 100% US, or even, I mean, if you have, as a company, if they can do their clinical study with European centers, it's better, or even French centers, it's even better. But the big mistakes is to spend money in poor methodology instead of just focus even on just one country, even if it's only US, but strong methodology. So then you have your clinical study, you have your comparative data, and that's good. So first mistake is that to have a not adequate clinical evidence plan. And the second is the economical, the tariff negotiation and the pricing strategy, which is sometimes not prepared, sometimes also not consider the typical French specificity. So listen to what these people say, because of course this is complex, but we have to also understand this complexity and adapt it to this complexity, not believe that this is black and white. So this is also sometimes the mistake some companies do in believing this is either too easy or at the opposite to complex. So they should know the pathway in which you are, because sometimes it can be easy, sometimes it's really complex, and you have to know and anticipate.
Excellent. Well, thank you very much, Michel, for your time. That was a very insightful interview.
Thank you very much, Oleg.